I'll just we just start the recording. Good afternoon, everybody in Ethiopia. So we have our series continuing today, and as the schedule has been sent to you all, we have 3 webinars this week and 3 more next week. We want to welcome everybody from all corners of the country here in the US and also from Ethiopia. So these 2 weeks, we will be focusing on basically respiratory care, ventilator management areas, and the outline of the presentations and the bios of the presenters has been already sent to you all. So please review that. In the meantime, we are also going to continue with other topics in the future. And so we will send you a survey so that you can help us identifying topics that are of interest to you. So we don't want to really be creating the topics unless they are relevant for you. And so Malaku and the rest of the team will be sending everybody a survey to indicate to us topics for discussion that you would like us to start anytime after this series is over. And the topics can be in any field, cardiology, infectious diseases, or others, but we really need your input on that. So please, please help us filling the surveys. Today we start with the mechanical ventilation introduction, and I think the basics, as the topic has said. The presenter is John Olson, who is a respiratory clinician with over 30 years of experience. He is someone connected to Ethiopia, having adopted 2 kids from Ethiopia. He has been to Ethiopia, has actually spent time in few hospitals, and has been a victim of your hospitality while he was in Ethiopia as well. John is going to really start us up with a couple of topics today and Wednesday. And as usual, we're going to start with the presentations, and I will be taking some of your questions through the chat system. And at the end, hopefully we'll have plenty of time for answers and questions. Yeah. If the answers and questions are not completed this time, we'll of course revisit the issues also on Wednesday when he comes back. So without any further delay, I welcome John. And John, the floor is yours.
Thank you very much, Carmen. So I'm gonna start with some basic mechanical ventilation for physicians. I teach the physicians where I'm at Mercy Hospital here in St. Louis. So I started to know what the basics are that physicians need to know. So here we go. So I usually start off with indications for mechanical ventilation. So you can see on the screen, apnea, respiratory failure, increased work of breathing, if they're hypoxemic, which it seems to be the big thing now with the COVID, that patients are hypoxemic for no reason. You look at their X-ray and their lungs don't look like they're full of fluid, and they're not heavy, yet I can't oxygenate them. If you try your traditional tried and true methods, which are increasing PEEP, to help you along there, that's not going to help with these patients. So it's a really sticky wicket where a lot of us are stuck in just the put them on assist control and turn them up to 100%, increase their PEEP. It's not working with these patients, so we have to really think out of the box. Indications also continue. So acute COPD exacerbation, or acute severe asthma, which can be a problem, especially in a polluted city. These are patients that are very hard to ventilate, that we tend to try not to ventilate, and we use other things to help avoid that by using BiPAP or maybe a high flow nasal cannula, lots of treatments and steroids and stuff like that. Because what's the problem with like asthma or COPD is that they can't get air out. So if I stick a little tube down their throat and I expect them to exhale all their gas out, it doesn't work like that. Cardiogenic shock, septic shock, and of course acute brain injury and flailed chest. So terms that I use for when I talk about a ventilator is the rate, which is the frequency of ventilation. So you and I, we breathe 12 to 14 times a minute, maybe 16 if you're smaller and you breathe a little faster. But that's our average tidal volume. So obviously these people we put on, they need more ventilation. Tidal volume, that's the amount of gas that is inspired and expired in a single breath. So tidal volume for you and I is probably somewhere around 400 or 500. These patients, sometimes we have to stick them on smaller tidal volumes to not injure their lungs. PEEP, positive end expiratory pressure, that's a really nice feature to have on your ventilator. With PEEP, I can increase FRC. If I increase FRC or I increase mean airway pressure, which it does both, I can actually help my patient. It says here, if I increase it over 10 centimeters of water pressure, may cause decreased venous return. Well, that is a possibility in a smaller patient, but a lot of times when we're using higher levels of PEEP, sometimes the patient is either sicker or larger and they may need that extra PEEP. Auto PEEP is when that patient doesn't exhale all the way and they trap gas inside their lung before they can exhale. And that's not a good thing. Can cause barotrauma, decrease your cardiac output because it's increasing pressure in the chest cavity, which will decrease your venous return. Okay? This is how we do our ideal body weight for, we calculate this. Actually, we have EPIC, which is a electronic health record that it figures it for us, but this is how you can figure it if you don't have that. You can, and I adapted it so it would go for Ethiopia, where you can use the kilograms and the centimeters. So you just start with a male is at 50 kgs and at 152 centimeters, and for every 2.5 centimeters, you add 2.3 kgs, and then you times it by 6 or 8, depending on what tidal volume you are targeting. Are you targeting 6 cc's per kilogram? Do you have real stiff lungs? Or 8 cc's per kilogram? We should never really be going over 8 cc's per kilogram for our tidal volumes, especially when you're putting someone on the vent. All right. Tidal volume times rate equals your minute volume. So that minute volume is really important. So I know if my patient's stable on a certain minute volume, if I switch modes, like from assist control, and we'll get to assist control and pressure support. If I switch modes, then I can be confident that if they're having the same minute volume or around the same minute volume, that they're going to be okay. I don't have to, get a blood gas or a ABG or anything like that. I'm fine with what's happening with that. Alveolar ventilation, that's minute alveolar times rate equals minute alveolar ventilation. So alveolar ventilation is tidal volume minus dead space. Normally, most of us have about 150 mils of dead space in our body. So that's dead space is gas that does not participate in gas exchange. It's what's in your trachea and your upper airways. It doesn't make it down to the alveoli. Okay, so it doesn't participate in that gas exchange. That's the only place that any gas exchange happens. So Anyway, support modes versus weaning modes. Assist control. So that's assist control is I as the respiratory therapist. I know you don't have them there. Okay, so we'll just say you as the doctor. You adjust the tidal volume. You control the flow rate. You set a minimum respiratory rate, and of course you control the fraction of inspired oxygen and the PEEP. Your pressure is variable in this. So you can see I always use me, but you guys are controlling a lot. When you breathe, nobody controls how fast you take your breath in, or how deep you take your breath, or how really your respiratory rate. You control all that. So assist control is a great mode to rest somebody, but they have to be sedated because they don't have control like they did before. Positive pressure ventilation can be very uncomfortable. It is not natural. When you and we breathe in, our diaphragm drops. It creates a negative pressure, and air goes in and fills up our lungs, fills up the alveoli. But with positive pressure ventilation, you got a tube down your throat, and positive pressure is forcing air down inside your lungs. So it can be uncomfortable. So we have to make sure our patients are properly sedated when we do this. That does not mean they don't breathe at all. It just means that they need to be in a zone where they don't mind not having that control. If the patient breathes above the backup rate in assist control, they get that same tidal volume. They get that same volume in. So like I said, they don't have to really work to get that volume in their lungs. So it's a good resting mode for these patients. All right. All right. I remember I told you, okay, so in pressure control ventilation, you set an inspiratory pressure by looking at the plateau pressure and volume ventilation. So usually at my hospital, we start with volume ventilation. But if we have to go to pressure control, I can use that plateau pressure. And the plateau pressure is when I put a pause on the ventilator, and it makes that patient hold its breath for 2 seconds or whatever. And so then I can get the amount of pressure it takes to keep the lungs open. So that's a good place to start for if I went to pressure control. Pressure control is a little more comfortable. I control eye time, but I don't control tidal volume. I don't control how deep that patient is breathing. I control the pressure. Also, that patient is getting a variable flow, so the patient can control the flow rate that they breathe in. It's a lot more comfortable than volume control, but the caveat here is you can't control that tidal volume. So the patient may take a larger tidal volume than you really want them to have. All right. If the patient has decreasing compliance or increasing resistance, you're going to see that volume will drop on pressure control. And with volume control, I maintain that consistent tidal volume. Weaning modes. So you can use SIMV. We don't use a lot of it here, but SIMV has a set rate and a set volume. I'm sorry. And we set what's called pressure support on there. So what happens is I'll set a rate of, say, 10. So you'll get 10 at a tidal volume of whatever I set, 400, 10 breaths. But it'll synchronize, and in between, the patient can have spontaneous breaths supported by pressure support. So pressure support is a pressure that it's sort of like you're riding a bike up a hill, and I come behind you and I push you. So you're doing all the pedaling, so the patient's doing the breathing, but that's a little easier because I'm making them breathe a little deeper with a little extra pressure. So it kicks in only on inspiration. And a lot of times we put it to support maybe to overcome the resistance of the ET tube. As you lower the rate in SIMV, the patient breathes more and more on their own with some pressure support. Like I said, we don't use that a lot here because sometimes patients get confused. They get in a breath where everything is controlled by me, like the volume and the flow rate. And then the next breath, they control a bunch. They control how deep they breathe and how fast they breathe in. So it's sort of confusing. Sometimes it's uncomfortable, and you can see dysynchrony when you use that mode. Pressure support only, that's what we do. We just go straight to pressure support. Some vents call it CPAP. The rates will be set at 0. So there's no tidal volume set. The volume will be variable. The pressure is the same. You have pressure support, which, like I said, augments the spontaneous tidal volume. A lot of times we wean our patients on what's called 5 of pressure support and 5 of CPAP. So they only get 5 extra of pressure when they take their breath in. So it can actually and we leave them on it for a while so we can make sure that they are ready to get the ET tube out. It depends on compliance and resistance, of course. And all ventilators nowadays have an apnea interval where you can set, if they're not breathing for so long, it'll kick into a backup rate for these patients and alarm at you so you know that they're too sleepy or stuff like that. So CPAP, so we don't use a lot of CPAP except for OSA patients with a mask. When we have a vent, we don't use CPAP hardly at all. If the patient has a big, maybe they're a drug overdose or something like that, we might put them on CPAP because they can take such big breaths and stuff like that. It's always increased airway resistance when you're breathing through an ET tube. So we always try to give them a little bit of support. All right. All right. So you can see, when can we liberate this patient from the vent? And the little dog says, I don't always breathe well, but when I do, it's with an ET tube. So that's not really true, but he liked it. Weaning, so I use the acronym MOVE. So that acronym, I take the first letter. So M is mentation. So when I'm looking at my patient and we've gotten over the initial insult that put them on the breathing machine, I look at their mentation. Are they awake? Are they alert? Are they on pressure support? Can they give me the thumbs up or stick their tongue out at me or lift their head up off the pillow? Then I look at the O part, the oxygenation. Is their FiO2 less than 40%? And their oxygens, their SATs are good. Are they greater than 92? We target usually 88 to 92 when the patient's on the vent. But once they get better, their oxygenation will go up. So their goals are higher there. And what's their ventilation like? Are they having to breathe a lot? Are they over 10 liters per minute with adequate, or less than 10 liters per minute with adequate acid-base valves? So you might need blood gases for that. I don't know what you guys have access to over there. I know when I was at St. Paul last time, they had a blood gas machine, but they didn't have the fluids that go inside it. So I don't know if you guys get blood gases. Other ways to estimate your ventilation part is to maybe have end tidal, so you have non-invasive end tidal monitoring, which end tidal CO2, which can actually be helpful to see if their CO2 is around 40 and 35 to 45. But if you don't have that, you can just look and see, is my patient struggling? Do they look like they're breathing easily? That's always a good indicator. A ventilation is why a lot of times we put patients on vents. And their expectoration, so that, do they cough well? That's a real important. You know, if you stick a patient on the vent because they had pneumonia and they can't cough when they come off, it's a problem. So they need to be able to clear those secretions when they come off the vent. They can't be suctioning them all the time. Weaning criteria for extubation, again, this all goes back to that MOVE, you know, that acronym. So what's my respiratory rate? These are really good guidelines for when you want to try to extubate somebody. So VDVT, that's dead space. You probably won't be able to measure that. I know the GE vent has capabilities, but there isn't a lot of vents out there that have that. NIF, that's negative inspiratory force, or just to test the lung muscle. These are good tests. That's a good test for patients that have Guillain-Barré or myasthenia gravis, and you're looking to see how if they're getting stronger or weaker. So. Shunt fraction, again, you probably need a blood gas machine. PF ratio, that's PaO2 to FiO2. We do a lot of blood gases over here. So, like I said, it all goes back to the MOVE. But the second last one at the bottom, the RSBI, the respiratory rate divided by tidal volume, you can do that on your own. You can put a patient on 5 of CPAP for 2 minutes and see if their RSBI is less than or equal to 105. So you take their respiratory rate and divide it by their average tidal volume in milliliters. A lot of the newer vents, like I said, will do this for you, but you can do it yourself in your head. You know, you can get an average tidal volume by looking at the minute volume over 2 minutes. Are just picking, you know, one of the average tidal volumes in there. And the respiratory rate at the end of that. I know, like I said, the GE will do this for you. The draggers, a lot of the draggers will do this for you too. So most of the vents that are within the last 20 years will do this for you. All right. Also, if you expect airway edema, say the patient had some neck trauma, or maybe you noticed when you intubated the patient that there was swelling down in their trachea or larynx. Make sure they have a leak when you try to extubate them. I would I would have them sitting there. I would pull all the air out of the cuff, give them a mandatory breath, and see if they leak, you know, gas around there, you know, and they should be leaking over 50 mils around that cuff once you deflate the balloon that's on the end. So those are things to be thinking about. If the patient passes the RSBI, we place them on, here at my hospital, we place them on 5 of pressure support and 5 of PEEP. And we usually do it for 30 minutes to 2 hours. And then we look and see, do they look upset? Are they diaphoretic? Does their blood pressure shoot up and heart rate shoot up, or is their respiratory rate high? These are all things we look at. End tidal's a really nice thing to look at it, and it's not a real expensive thing to have. Most monitors have the capability of doing end tidal if you get the right attachments, and most of the attachments are disposable and fairly cheap. I don't know about accessibility in Ethiopia, but maybe that's something we can work on. So, all right. Oh yeah, here we go. Sometimes ventilators are like this. You got to smack them real hard. No, let's get the tube out. That's what we want to do, and then we don't have to worry about our ventilator. All right. So thank you for listening. So we'll listen. I'll take questions now. Sorry. Garma?
Okay, thank you, John. I think a lot of terminology, a lot of basic stuff, and there is a lot to build on this on Wednesday to continue further the discussion. And you know, John, I didn't really go into your connections with Ethiopia and some of the work you had started with Elias to do. You
Yeah.
know, maybe as we collect some questions, can you elaborate a little bit about your exposure, what you have seen, and what you guys are planning to do, so that people can be aware of the work that is being done?
Well, what we're planning to do, you'd have to ask my boss, Ilias. But what we have done is, so Ilias was a fellow at Mercy. I don't know, like, what was it, 4 years ago? Something like that. And then he, we were talking, I told him about my kids. I have 3 adopted children from Ethiopia. I really enjoyed going over there, and I saw that their health system was struggling, you know. And I thought, well, I can do something about that. I mean, honestly, I'm happy that somebody would want my skills. They don't have respiratory therapists over there and stuff like that. And he said, yeah, they don't have any. He goes, why don't we do a mission trip? And I said, what? I go, I don't know. And so he sort of challenged me, and then so we did. And I remember he told me, well, contact some of the hospitals over there. And so I know that there was a hospital in Soto that answered me, and then we got another answer from a hospital in Awassa, and then Ilias had friends at St. Paul, so we did like 3 hospitals in 10 days, and it was kind of a whirlwind tour. We tried to help as much as we can. I did teaching at each hospital about respiratory therapy, taught mostly the nurses. Some of the doctors brought ventilators and a bunch of respiratory supplies. And so the last time, so I went, this was like 2 years ago. And then the last time I went was a year ago. And Ilias was supposed to go with me then, but he did not. He had things he had to do. And then his brother was kind enough to be with me. And then we ended up going to Soto again. So it was funny because the first time I went to Soto, their NICU was just and I've got a PowerPoint on this too, I can show you guys, but their NICU was just a isolette and a big oxygen tank. And so they had babies dying and stuff like that. And so I said, I'll bring them a ventilator. I'll bring them an infant ventilator. Because so I went back there again, and they had adult ventilators on infants, and I thought, oh my God, this is terrible. So I brought them an infant ventilator, and now they're doing really well now, saving babies. Sometimes when I went there the first time, the doctor was Australian that was at Soto Hospital. It's like a Christian hospital. I guess they have missionaries and stuff like that. But they told me, they said, we have 1 ventilator here, and people, you choose who lives and dies. That's why when we had the COVID here, and New York's talking about that, I thought, God, they do that all the time in Ethiopia. People have to choose who's going to die, who's going to live. So. I mean, it's not a great choice, but it's a choice. It's something sometimes you got to make those choices. So anyway, I have a real different outlook on my healthcare. We are spoiled here in this country. I can do a CT scan when I want to, or MRI, or I get a blood gas, and you can't do that in some countries. So you actually got to use your assessment skills, which is really important. And I think they can take you farther than a lot of this testing. So
there are a few questions for you that are coming this way, and maybe towards the end, when the questions are done, maybe we have a larger audience, so you can really tell people, what do respiratory therapists and respiratory clinicians do? Because that's a As you may have seen in Ethiopia, it's a different training. And so maybe you can recap on that. But first, a question. So here is one that says, it's from Aptamu. The question is assist control mode, if the rate of patient is more than the set value, does the minute ventilation increase?
Yes.
Or can I use pressure control volume plus, synchronous SIMV and with pressure support? So what are your thoughts there?
So I'm not sure if I understand. So he says
there are two questions. One is, you have someone on assist control. If the rate of the patient's breathing rate increases, would the minute volume increase? That's one.
Yes, it would. It would, only because they're going to be supported with that volume that you have set. Every other breath over that is going to be that volume. So yes, the minute volume would increase.
And the second question is, can I use pressure control ventilation or SIMV with pressure support?
Yeah, you can, or you can use, and I didn't get into this mode, but it's Haptamu. That's from where? Where's he at? Where's Haptamu at?
I don't know.
Oh, okay.
I mean, they can be from anywhere in the country.
He can, if that patient wants more minute volume, if they're breathing higher, then he should really consider, yes, going to SIMV, or maybe just going to pressure support, and maybe even a higher pressure support. Whoever said that I had to use 5 or 10 of pressure support? I can use 20 of pressure support. If my patient has a drive to breathe, why wouldn't I put them on the most comfortable mode? And pressure support's the most comfortable mode I can offer a patient. So
that is really to take your analogy, that is really that pushing, the guy on the bicycle up the hill, just giving a little more help. Okay. So the next question is from Dr. Ondos, and he wants to know, how can we assess lung compliance for COVID patients who are on the vent, and role of CPAP in acute respiratory failure with COVID-19 pneumonia? What are your thoughts?
Well, I'm sorry, I'm having trouble with that first one.
Two questions. One is, how can we assess lung compliance for this
on a patient on a vent?
Yes, including the COVID patients. Mm-hmm.
Okay, so you can assess lung compliance by doing a plateau pressures, and that plateau pressure is a inspiratory hold. And like I said, all vents do this. All you got to look for that inspiratory hold button, and you look for and a lot of them will figure lung compliance for you. But if you want to figure it yourself, you can do that yourself. You can figure, you can take your plateau pressure minus your volume divided by your plateau pressure minus PEEP. Okay, you can do that yourself. All right. So
that volume is what volume?
Your tidal volume, your return volume. Mm-hmm. So that's in milliliters.
Okay. So, and then the second question is, the role of CPAP in acute respiratory failure, particularly in COVID patients. What are your thoughts?
So CPAP, depends. I would rather use a high flow nasal cannula. That would be mine. I would, if I can, it depends on what type. Do they have H or L COVID? So which phenotype? So if they have the one where it doesn't affect the lungs as much, I think that's H. I'm not sure. I know there's a H and L. Anyway, the one that doesn't affect the lungs so much, oxygen's the key to treating that. You can put them on a non-rebreather or a non-rebreather with a cannula under. Just bombard them with oxygen. Or if they have the one that has the that looks more like ARDS when you do a CT scan or a chest X-ray, then you're going to want to put them on some extra pressure, and CPAP would have a role in that. So.
So
Ramon, let me say
I
a couple
think,
of things.
yeah, oh, please add, because there was some implication the last time you remember for about aerosolization of the problem. So Elias, would you add anything?
Okay, let me say a couple of things. And John, that was a great lecture, and I think this will set the stage for the next few. So a couple of things I want to add is a couple of things. Number one, before I answer the question, I think what we do here, and I think what you guys should do, is you should have one mode of ventilation everybody's comfortable with.
Yeah, I
And
agree.
like, yeah, John said earlier, the volume control usually does the job. So,
Yeah,
and don't complicate things. And that is the recommendation too,
yeah.
is to stick with the volume control. There will be patients who won't be comfortable, won't get what they want with that mode. So it's good to know the other modes, and especially have more trained personnel coming out of the fellowship trainings, and eventually people, most facilities will have trained intensivists or pulmonologists, but right now I know very few do. But even those, without the help of respiratory therapists, because they are actually the one who knows the vein, right? So we don't have that yet. And St. Paul is doing a great job training that, but that's gonna take a while. I know there are private hospitals in Addis who has their own respiratory therapist, and they're doing some work
Do they
during
really?
COVID. Yeah, too. So that will come. But right now, I think that is the message: is stick to one and look at the patient. And there's always this other option. If your patient is not comfortable with that mode of vent, and he is or she is deteriorating, like with oxygen is going down, blood pressure is going down, always make sure you disconnect the vent, right? That's always the right thing to do. Disconnect and move back. You can deliver good pressure and oxygen without killing the patient while you're figuring out why the patient
Is deteriorating.
right?
Yeah,
You can,
we always take them off the vent as soon as if we see them starting to crash like that. So
yeah. So you can always call your friend, or you know your the intensivist at St. Paul, your friend or someone, and get help. Because otherwise, patients die. Remember, so this is a necessary evil. So this is from what we've seen during our trip, and I'm sure you guys noticed this, because some of the patients are on extraordinary amount of pressure when you see that. So, which means unfortunately we are causing barotrauma. So just keep that in mind. That is one, especially in this COVID time, as we discussed last time. I think the most important thing to remember is avoid intubation if you can.
yes,
Because that's our experience. And most of the patients, if they get intubated, and very few of them actually make it out.
you're
Now,
right.
there are a lot of theories, you know, the low elastic resistance, high elastic resistance, you know, type H and L. So, I mean, you know, those are still, those unknowns. And so, but remember that use your oxygen without intubation first, and your proning and all that. So that is the most important thing I want to. And to answer your question, so you are not just supposed to use any BiPAP with COVID because of infection control issues, right?
Well,
And
we use it in a negative pressure room, and we have a filter on the expiratory thing.
Exactly. So now, so you have to know what you're doing when you do it, because remember,
You do.
so we don't use it in our facility.
Oh, okay.
And no, I know, John. So remember how. So this is how we've come a long way, right? When this started, high flow was a no-no.
Okay.
Because the feeding, we were not sure about the feeding, and we were concerned about infecting healthcare workers, which is going to be very important. That Dr. Dowd has been saying this again and again. So
We
the
put a
most important
mask
thing
on
is
the patient when we
exactly.
put that high flow on. Again, it's a negative pressure room. We have enough of those. So
Exactly. So you have to know what you're doing when you. We don't have a high flow in
I'm
Ethiopia.
sorry, I shouldn't have mentioned it.
No, it's okay. It's okay. So we don't have high flow. So the non-invasive ventilations in Ethiopia we do. So we do have CPAP.
Yeah, but you
We do
shouldn't
have
be using
BiPAP.
them. Yeah. Yeah.
So right. My suggestion,
It's
unless you have very good hand in infection control, I think you risk exposing yourself and other healthcare workers. So it's better to have a closed loop, which intubation does for you, than experiment on the BiPAP. That's my suggestion. We don't use it in our facility. I think but now, so you again, and how many of our units have negative pressure? Dr. Dowd will comment on that. But I mean, you can open the window and create some. But having said that, I would not suggest using BiPAP for COVID yet.
Good. Dow, do you want to add anything?
Yeah, like Ilya said, and I was saying before, non-rebreathers are really good. You can put a non-rebreather on a patient, and you can stick a cannula underneath. That should be the first line for the for those COVID patients is give them more oxygen. Okay.
All right, thank you. And
Yeah.
Dr. Dowd was going to
Good
say
morning.
a few words. Yes, go ahead.
Yes. Good morning, Dr. Wendosan. I see you in my screen, by the way. My experience is what we are doing here in our hospital, and we're not using BiPAP as
Okay.
other patients. They are using it very rarely, but BiPAP in general for COVID patients is kind of last resource.
Yeah.
So and the reason, and in Ethiopia, it takes actually much more precedence because very limited healthcare resource. Infection of medical professionals is at the top of the list. Preventing infection is at the top of the list. So I think if we are, it's going to be with probably high flow oxygen non-rebreathe mask than to ventilator if it is possible. I mean the respiratory, the critical care physicians will weigh in more, but more and more, the more I see the apprehension here, I really feel that in Ethiopia it will be very difficult with the limited resources that we have and risk of infection of medical professionals.
Thank you. And so there are a few more questions, John, for you.
Okay.
So one is, could you clarify and explain a little bit more about the air leak test you mentioned? Because I think some people did not get it clearly.
Okay.
When you're talking about extubation, if you can just go over that one more time.
So what we do is we deflate the cuff so that the ET tube has a balloon on the end down in the patient's trachea, and so we deflate that and make sure air can come around it. So sometimes patients have maybe it was a traumatic intubation or they may have gotten had some kind of trauma done or some kind of infection that maybe made some swelling in the larynx or in that area. And if you deflate that cuff and you make sure that at least 50 mils of volume is lost up through their upper airway, then you know that you've got a little bit of a leak around that the ET tube that's down there, and it won't. And when you pull it out, the patient's airway won't swell up. So that's how we test that here. So,
and if I add a couple of things, so that's going to be important because, so like John said, you do it whenever you have suspicion of upper airway swelling, right? For whatever reason, was there anaphylaxis, or the trauma, or the infections, or the patient is intubated prolongedly. Sometimes that by itself can cause edema. In this COVID period, most of our patients are intubated like for weeks. Now, what couple things you can do, like John said, you deflate and see the volume, or even hear. You can hear the air leak. You can hear actually the air leak. It makes noise. And the other, if you do, so now, by the way, having said that, this theory, doing air leak with every extubation is no. We don't. We used to do that long time, but it's not recommended to do it on everyone. But if you do have suspicion, for those reasons John mentioned, you can do that. If you do, then, I mean, what most of us do is we give them steroid 24 hours before we extubate them. That tends to help with extubation. Now, if you have a contraindication, of course you can. But just from experience, there's no lot of data on that, though. Now, having said that, can I add a couple things?
Yes, of course.
Please, as weaning is very important, as my friend said. So think about weaning. It's very important. Every day when you round, your first two questions is, we can stop the sedation. Can we extubate this patient? No patient should be intubated unnecessarily, even overnight. So please remember that, and that's the resource management as well. And this troubleshooting thing, that brings me one of the plan we might have down the road is, and hopefully Dr. Girma and Malak, we have to work on this. So this troubleshooting on the vent or any medical issues, I think we will try to create this 1-800 numbers down the road, part of the collaboration. So maybe some of us will be available for you guys to troubleshoot. I just want to mention, put this in your ear for now.
Yeah, no, thank you. So one more question for you, John, which is, calculating or measuring. So this is, I'm just reading directly from the chat that is coming. Where do you measure tidal volume, or where do you monitor, minute ventilation, and how do you see all those numbers, and how accurate are they? And if you said something, how do you know if the patient is really getting what you have said? So it's just like a general question, both to read, I guess, the mechanical ventilators, depending on the different machines. I would assume all of them have a spot where you can see how much volume is given to the patient, right? And
yes, and I would assume that too.
Yeah.
And actually, ventilators, I'd say since the 60s, have all had some kind of readout where you could see, maybe mid 70s, but even then, they had to have some kind of readout where you could see the volume that comes out of the patient, and then they figure out minute volume by the breaths per minute and how much volume that's expired. Inside the ventilator itself, there are sensors that they're flow sensors, and that's how they calculate the volumes and the minute volumes and the pressures and stuff like that. So if your patient's chest is, you can see it rising and it doesn't rise too much, or if it doesn't rise at all, then of course you're not giving a volume. So
Yeah.
you really have to do some assessment with that. So
yeah. So at this point, can you just mention to us some of the topics you're going to be covering next on Wednesday? Because I think this is a follow-up. Maybe do we go into the modes? What do you cover on Wednesday so that people can know what's coming?
I was going to look at waveform analysis, but some basic waveforms that it's easy for you to pick out, like what's happening with your patient, whether your patient has a pneumothorax or maybe the patient has a lot of secretions, or maybe the patient is a bad asthmatic or a blocked tube and isn't exhaling all their gas out. That's what I was going to go over, but
Good. So the other question that coming up is, from respiratory therapist or respiratory clinician perspective, the initiatives that you and Elias have kind of started, where is it at? So what does it look like? How can we make this, to the next level in terms of, having clinicians that are trained in this field? Who can that, so what are the initial thoughts and what have you guys done so far in understanding that piece?
I think I'll let Elias answer that. How about that?
So I think as part of this, actually, I've invited the director of that training, Abtamo. I don't know whether he's online. If he is, and
he
I
is.
will
I think
invite him.
yeah, I think he is. Yeah, there is a halftime who is asking.
I'll just give a brief. So this is actually an initiative started by St. Paul. It was on the shelf. We just helped get it out of the shelf. So this is not our initiative. We just helped with their starting. So this is their own project that's been sitting for a while. So I don't want to take that credit. So having said that, so we help in reviewing the curriculum and material-wise, John has been instrumental, and moral support mostly what we've done. So, and Abtamu, are you here? Because I saw, so it's a little hybrid program that they decide to start, because it's always hard to start from zero. So what they decide to do is take the nurses who are already trained and train them with a respiratory therapist as well as public health and give them a master's in science. So, and they have started that about 4 or 5 months ago. They finished their first semester, and they were about to go to the second. Unfortunately, the COVID thing paused everything. So what they need, for anyone who's listening,
yeah,
they do need personal support, RTs, volunteers, and they do have a lot, but they don't have any dedicated other than Abtamu, who's trained in a respiratory therapist, who's running, and of course material support. So that's where we're there. They have about 10 or 11 already enrolled, and will graduate in a year and a half, and I expect. So that's where the program.
Yeah, I think Abtamu just sent a text message saying, yeah, yes, we can give masters in respiratory therapy for BSc nursing candidates. So I think they must have a curriculum in place, and maybe at some point offline we may have to discuss ways that we can help support the program to grow.
Oh yeah, Girma,
so,
like I said, they have started the program. The program has already started. Okay.
Yeah. So if they have a curriculum, I mean, we can maybe help them grow if there is some additional coverage from teachers' perspective or materials perspective, so we can be a little bit more intentional and be involved and engaged. There is a question from Dr. Gamechis here. Some areas don't have viral filter. I guess, I don't know if that means if the filter is on the ventilator or if this is a negative pressure, if that's what he means. But he's asking, how do you see pre-oxygenation with masks or non-invasive measures before mechanical ventilation in COVID patients? I would assume that's probably what the question is.
Yeah. So like I said, and like Elias has said, we should not probably use non-invasive at all. I mean, if you don't have a negative pressure room and you don't have a viral filter that you can put on your expiratory limb, then we should avoid intubation as long as we can with oxygenation. And actually, I wanted to mention something interesting is that we are also proning patients that are spontaneously breathing. So, and actually we've had a lot of good luck with that. So you can prone patients that are on a non-breather it may not be the most comfortable for them. It may be a little ketamine or something to take the edge off, a little Ativan. But we've had a lot of good success by proning our patients ahead of time. So, you know, proning them while they're spontaneously breathing. So.
Yeah, I think this proning issue probably requires a little bit more detailed discussion, because
okay.
you know, I do believe it requires a lot of planning, and you know, things can go bad in patients who are also prone. So I'm not sure if Elias and your partners together, if you guys can come up a little bit more in a detailed discussion about prone ventilation, because we have heard a lot about it, but I'm sure, like anything else, it has its own processes. So let's think about it and see if there is something we can add value to it. And in terms of the nursing training for respiratory therapists, you know, how long is the training? Is it a year and a half? Is it 2 years, Elias? Do you know?
2 years. It's a 2-year program right now. Like I said, I think that's Ethiopian context to give the master's. So it's a 2 years program. These are what we call train the trainers. So these are going to be the teachers. So that's why it was, I think, decided to do it as a master's. And but the next batch, my hope and guess is going to be starting from after high school. So it will be a 4-year program at the bachelor. But this one is a 2-year program. And depending on the success of this one, then the next one would be decided whether it's going to be 2-year or just a brand new 4-year program.
So Daud, like a lot of, this question was from Daud, and, like a lot of the master's program, they are always considered 2 years. And, that is just by law or rule or whatever known in Ethiopian context. That's how the master's trainings are actually concluded. So I think this conversation will continue, and we are looking forward to Wednesday webinar. And as John mentioned, understanding ventilator waveforms, can tell you so much about the patient care you are giving through the ventilator, and can help you actually go through troubleshooting and understand really the mechanics of what you're doing to the patient. So it's an important basic thing to attend to. Unless Dr. Wondosan has some additional question or thoughts he wants to add, I just want to give him a minute opportunity to say if he has some questions or comments from his side.
Just say thank you. I mean, it's of immense help, It helped us to revise our basics, and particularly at this time, the topics that are being discussed are really very useful. Thank you very much. So I'll keep on attending. I hope it will expand to other ID fields. God's help, and we'll make it a case-based discussion. Because now there are no classrooms.
Yeah.
Thank you very much.
Yeah, we are going to work on it.
Absolutely.
Otherwise, I really appreciate everybody coming online, and thank you very much. Same time again on Wednesday, and see you there. Thank you, John, for today, and see you on Wednesday. Thank you.